Observe the integrity of the skin for any open wounds, burns, open fractures, abrasions or bruises. Look for any redness for signs of infection or inflammation. Take note of the olecranon bursa, which if a bursitis is present will be prominent, swollen, round and red. Look for any further signs of swelling around the whole aspect of the elbow joint, including the distal humerus and forearm. Observe the soft tissue attachments, especially the lateral and medial epicondyle, which are the common extensor and flexor origins. Observe the overall posture of the limb and any protective behaviour. Look at the overall alignment of the joint for any possible elbow joint dislocations, subluxations or fractures. Observe the radial head is articulating with the capitulum. Observe the carrying angle. When the forearm is in full extension and supination, there will be a physiological valgus of 9 to 14 degrees. In women, the angle will be 2 to 3 degrees greater. This angle allows the elbow to be tucked into the waist depression above the iliac crest. It increases when a heavy object is being lifted. Any increase in or loss of this physiological angle is indicative either of major elbow instability or of malunion. Palpate posteriorly to start with. You can support the humerus to allow greater manoeuvrability of the joint and access all structures. Palpate down the posterior humerus, checking for bony tenderness, and the triceps muscle can also be easily felt. The three palpation landmarks of the posterior elbow are the two epicondyles and the apex of the olecranon, which form an equilateral triangle when the elbow is flexed to 90 degrees and a straight line when the elbow is in extension. If these are not in this alignment when palpated, suspect a possible fracture. The posterior aspect has the olecranon, which can be palpated midway between the medial and lateral condyle. Slight elbow flexion will bring the olecranon out of the olecranon fossa. In this position, the proximal portion of the fossa on either side of the triceps tendon may be palpated. The olecranon bursa can be palpated on the tip of the olecranon, and this is also where the triceps inserts. Standing to the side of the patient. On the lateral aspect, palpate the lateral epicondyle. This can be assisted by asking the patient to lift their wrist to activate the wrist extensors. Palpate superiorly for the supracondylar ridge and the radial head distally. The radial head is palpated with the examiner's thumb, while the other hand is used to pronate and supinate the forearm. The head is about 2 centimeters distal to the lateral epicondyle. Palpate further down the radius to identify any bony tenderness. The elbow joint is palpated inside the triangle formed by the bony prominences of the lateral epicondyle, the radial head and the olecranon. This palpation will reveal any subtle effusions or mild synovitis. To palpate brachioradialis, the patient is asked to clench his or her fist and flex the elbow with the forearm in neutral position against resistance. The wrist extensors are palpated by asking the patient to extend the wrist against resistance. Extensor carpi radialis longus produces both flexion and radial deviation of the wrist, so to palpate this specifically, ask the patient to perform these movements. The medial aspect of the joint is not very accessible to palpation, and the small amount of synovial tissue on the medial border of the olecranon makes joint palpation difficult. You can palpate the medial supracondylar ridge and down into the medial epicondyle. Then follow the ulna distally to feel for any bony tenderness. To palpate the wrist flexor origin, ask the patient to flex the fingers and wrist, and the common tendon can be felt. Move posteriorly to palpate the ulnar nerve in the cubital fossa. Moving anteriorly to the antecubital fossa, palpate the biceps by asking the patient to supinate their forearm with a flexed elbow. Your finger should be able to hook under the biceps tendon. If you are unable to do so, suspect a biceps tendon rupture or partial tear. This is called the hook test. Also palpate this muscle superiorly into the bulk for signs of a tear or any muscle strain. The brachial artery pulse can be identified medially to biceps. This should be assessed especially if a supracondylar fracture of the humerus is suspected, as dislodged fragments can occlude the artery and cause a Volkmann's ischemic contracture. Quickly assess cervical spine range of movement to assess to see if the origin is a C5, C6 nerve root irritation that can mimic a tennis elbow. Observe the active range of movement of the cervical spine, bilateral side flexion, rotation, flexion, extension, protraction, and retraction. Ask the patient to actively move the glenohumeral joint into flexion, abduction, place the hand behind the back, and external rotation to eliminate any glenohumeral joint referred pain or problems. Elbow joint. Ask the patient to actively flex, extend, supinate and pronate the elbow. Passive range of movement. The clinician supports the forearm with the patient as relaxed as possible and not activating any muscles. Then the joint is passively moved into flexion, extension, pronation, and supination, noting any pain or difference between the active and passive range of movement. If they have, for instance, full passive elbow flexion and very painful restricted active elbow flexion, suspect a biceps or brachialis strain or tear. Muscle testing of the elbow joint. Biceps. With the forearm in supination and flexed to 90 degrees, resist elbow flexion. Triceps. With the forearm in supination and flexed to 90 degrees, resist elbow extension. Brachioradialis. With the forearm in the mid position of pro and supination, resist elbow flexion. Wrist flexors. Flexor carpi radialis and flexor carpi ulnaris. Resist wrist flexion with the elbow flexed to approximately 45 degrees. This will be weak and positive for pain with a golfer's elbow. Wrist extensors. Extensor carpi radialis and extensor carpi ulnaris. Resist wrist extension with the elbow flexed to approximately 45 degrees. This will be weak and positive for pain with a tennis elbow. Tennis elbow. With the arm rested on the patient's lap or on a table, resist middle finger extension. A positive sign is pain reproduction in the common extensor origin. Ulnar and radial collateral ligament injuries. To test the ulnar collateral ligament, have the patient's elbow flexed and supinated. Grasp the humerus just above the elbow joint with one hand and the forearm with the other. Move the forearm laterally. To stress the radial collateral ligament, move the forearm medially.